So Richard, tell me this: when you clinically, when somebody's on TAS-102, how often are you doing their counts? Because neutropenia, as you know, was the big one. Counts was how often do you do the counts, and do you do any dose adjustments like you would do for regorafenib, but for a different reason?
So I think there's some data that is for TAS-102 at least it is dose dependent. It is a cytotoxic chemo, so dose does matter. So there are some trend, at least in community, they start to underdose, maybe because of the sort of experience they got from regorafenib. But there's clear data that dose does matter in TAS-102, and the recommended dose is 35 milligram per meter squared BID, day 1 through 5.
You get the weekend off, and then
weekend
off, 5
then,
again.
Then you go to the other week on. So, per label, you're supposed to see the patient by day 15 to check their counts. However, I do see the patient by day 15. Just look at the toxicity, make sure the patient has no other toxicity other than neutropenia, fatigue, or other problem. However, there's no correlation between day 15 counts and cycle 2 day 1 neutropenia. So even though we check it, I don't know what it really means, okay? So therefore, when I see the patient by cycle 2 day 1, depending on their counts, we do have to dose delay or dose delay sometime if, for example, I think per guideline, ANC of less than 1,500 or platelet count less than 75,000 is the sort of the guideline they give. So if it's below that, we do have to delay 1 week, then restart at the same dose. And not dose reduce when the counts come up, but actually dose delay. There are certain indications that it is recommended that you dose reduce. For example, if you have febrile neutropenia as an example, when you have to dose reduce.
Okay, thank you for that. Mike, is that the same for your practice?
Yeah, absolutely. And Richard emphasized the important point that it's been observed that from the pivotal trial that most patients, if they have any alteration at all in the administration of the drug, it's actually just a delay. About 50% of people ultimately needed a delay, but a very small number of people needed a dose reduction. Almost nobody needed to stop the drug because of intolerance to it. It was mainly stopping for progression. So I think it gives us comfort that you can keep people on the recommended dose, and it will be tolerable for people, even if it requires a week delay before their next therapy.
Well, thank you, Greg, Mike, and Richard. This has been a great discussion. So as a take-home points, at least when patients present with the frontline colorectal cancer, metastatic colorectal cancer, we need to at least do their testing for extended KRAS, KRAS and NRAS, BRAF, and microsatellite instability. The NGS about doing the next-gen sequencing is dependent on the physician, what do you think about the clinical outcome of the patient, but it can give us really good targetable targets. And one thing that we didn't talk about is HER2/neu. That's a potential thing that should be tested in these patients. About 2 to 2.5% are HER2/neu over-amplified, and there are studies out there to use targeted agents against that. So that's very important, but that's physician-dependent about when they think about the performance status of the patient. Everything has to be taken into consideration. For third-line therapy, it's again, you have to look at the clinical scenario that you're faced with, different toxicities, and based on exactly how your patient presents, you can either choose to go with regorafenib or TAS-102, depending on the unique toxicities. The dose adjustment is also unique in both the oral drugs based on the toxicities, but that's purely dependent on how your patient is doing. So thank you so much for that discussion.